So I'm going to start off by actually asking Dan some questions, and I think that that way you'll really get an idea of the disease state and its implications on the patient. So Dan, if you don't mind just telling us how, actually you're actually from out east, right, Nova Scotia, right? So what actually brought you here to McMaster, and how did things get started with respect to the disease?
I came up to McMaster in 2006. I was recruited to come up to swim with the swim team, the varsity swim team at Mac. So I arrived early September and first was diagnosed with kidney problems in late October, having back pain and swelling in my ankles and legs. I went in to find out what was going on and was diagnosed with kidney problems at that point.
And I think when you say swelling, I really want the audience to get an idea what swelling is, not just the kind of the usual swelling, but how swollen were you? Do you recall again?
Initially, it was basically a straight from my knees right down to my ankles. There was no definition, no change. It was just a straight down swelling in the legs. So I was quite large and wouldn't be able to tie up my shoes. My ankles were so swollen by the end of the week when I first went into hospital.
Okay, all right. And so kind of what happened afterwards?
I was put on drugs like prednisone and there was no changes. So come January, after I was home for Christmas, they did the biopsy and found out that it was the focal segmental glomerulosclerosis. At that point, just tried different drugs. Nothing seemed to work. And by April, I was first put on dialysis April 1st, and at that point, I was about 65 pounds of fluid, so just about 27 liters or so of extra fluid on my body at that point. And I was hospitalized a week late March because I was having trouble even getting dressed by myself. Bending over to reach my ankles to put socks on was quite a difficult task because I was so swollen.
Right. And then there was no hint of this in Nova Scotia, so when you came?
Previously, I have no family history of anything with the kidneys. There was no side effects that I really could pick out from when I was in Nova Scotia in grade 12 or even the summer before, before I came up to McMaster. So it was quite a shock for me.
Okay. So I guess one of the major questions that Dan had is that do all people who come to McMaster get this disease? And we reassured him that it wasn't the case. So Dr. Margetts actually was a first nephrologist to see him. And really, Dan really was extremely swollen. He had the puffy eyelids. He really had fluid right up, even up to the thigh level. If I recall, by the time I saw you actually had fluid in the abdomen, and it was really quite extensive. And and that's kind of how we define this as far as edema goes. The amount of fluid that you have. So physicians have a bit of a scale, and Dr. Margetts at the time thought maybe he had 3+ edema right to the abdomen. His blood pressure was elevated, as you'd expect, because he was retaining a lot of salt throughout this process, and therefore his pressure was up as well. This is a marker of his kidney function. So really his kidney function test was actually normal. And that's not surprising with patients who have nephrotic syndrome, is that initially their kidney function is totally fine, but this is also a diluted version of creatinine, because you can imagine that if he's retaining almost 20, 30 liters of fluid, this is going to be quite diluted down. His albumin was very low as well, as he was spitting protein in the urine. And that's basically a manifestation of this over here. So we do a urine analysis to see if he's spitting protein, and he was spitting quite a large amount of protein as well as a bit of blood. This doesn't tell us accurately as to how much protein Dan was spitting, so we actually went out to do a 24-hour urine collection, and he was spitting over 22 grams of protein per day when the normal is about 150 milligrams per day. So this is quite significant, and with this he also was, his cholesterol levels had also skyrocketed, and I'll talk about this in a little bit as well. So based on these characteristics, he was diagnosed with having nephrotic syndrome. So nephrotic syndrome, by definition, is patients who present with a heavy amount of proteinuria, so over 3.5 grams per day, in association with edema and also hyperlipidemia as well. So he fit that idea, but again, saying nephrotic syndrome isn't really a name of a disease, it's more of a name of a syndrome. So it's not really saying a specific disease is a cause. So he was started on initial empiric therapy, and so what we try to do is take the pressure away from the kidney cell and try to decrease the amount of protein. So we target the renin-angiotensin-aldosterone system, and so he was on a medication called ramipril, which is an ACE inhibitor, angiotensin-converting enzyme inhibitor. He was placed on furosemide, a diuretic, to help reduce the amount of fluid he was retaining. And then to treat nephrotic syndrome, there is a general approach to treating nephrotic syndrome in the sense that we just give prednisone empirically to see if this will actually help patients. And then he was also placed on a cholesterol-lowering agent since his cholesterol was so elevated. But despite this, really, his protein excretion really did not change, and so adrenal biopsy was then undertaken. So this is just an idea to give you. This is just to give you an idea of how much protein somebody could be spilling with a simple test such as a urine test that often our family physicians and we do in the clinic. So if you get a urine trace over here, you could be spilling anywhere between, in the normal range of 150 milligrams per day, almost up to a gram per day. If it's 1+, it could be up to as high as 2 grams per day. And Dan was in this 3+ range, as you can recall, and he really could be, he was over between 1,500 milligrams per day all the way right down to nephrotic range proteinuria. So what are the characteristics of nephrotic syndrome? So we kind of looked at the definition briefly. So a protein excretion of more than 3.5 grams per day. Most of this is often albumin. Edema, so this is basically leg swelling. Hypoalbuminemia, because they're spitting so much protein that their actually serum albumin level drops off. They can get elevated cholesterol levels, and this is partly because they're losing the protein that actually cholesterol uses to transfer. So apolipoprotein beta proteins will all go down in the urine, and then secondarily they get a hyperlipidemia state. The liver's also, liver's response also to this lower protein state is also to manufacture more cholesterol as well. They get a hypercoagulable state because they're losing their transient, your anticoagulants, your natural anticoagulants that you would have in your blood. So they tend to be more coagulable. Also, these individuals are really like the Michelin Man. If you picture a Michelin Man, that's pretty much what poor Dan was like at the time. And they're immobile, so they're not moving as well, and again, predispose them to blood clots. And then there'll be one that I just talked about. So what's the mechanism of nephrotic syndrome? So there's two theories as to why people become so volume overloaded. There's something called an underfill theory and something called an overfill theory. The underfill theory is classically your albumin concentration drops in your intravascular space, and therefore your oncotic pressure decreases. So if your oncotic pressure decreases, essentially you can maintain the fluid in the intravascular space. Everything starts to spill out into the tissues, and with that, in response, you get hormones that are released. And specifically, a major hormone that's released is renin, and then secondarily angiotensin II. And this activates aldosterone, so you have a lot of salt retention due to this. There's also a hormone called atrial natriuretic peptide, which in low intravascular volume states is released, which also retains sodium. And then something called vasopressin, or antidiuretic hormone, which is also released. Usually this is only responsive to plasma osmolality, but in a case where you have severe volume, intravascular volume depletion, this will get released. And so all of these cause a profound amount of volume retention. The overfill theory actually is kind of the exact opposite to a certain extent. It says that the proximal tubule is at fault, and we do, as nephrologists, it's never the kidney's fault; it's every other organ's fault. So we don't really believe in this too much. But having said that, the proximal tubule is the agent over here that's actually at fault, causes a lot of salt retention, and again, with this, goes on to release. It goes on to release a bit of vasopressin, but it's actually not elevated. Unlike in this state, your atrial natriuretic peptide is elevated, but your aldosterone actually on the lower end. All of this eventually, this excessive sodium salt retention leads to sodium retention and then edema. So those are the two prevailing theories that are out there. So you have nephrotic syndrome and this diagnosis, and like I said, this is not really a name of a disease. So we will try some non-specific therapies initially, and really that's what Dr. Margetts did to start off with. So we put him on ramipril to target the angiotensin aldosterone system, and he also put him on prednisone. And the prednisone was really thinking that maybe he has something called idiopathic nephrotic syndrome as a cause of it. But nephrotic syndrome can actually be divided into primary or secondary. And primary is basically doing a biopsy and looking at the microscope as to the structure of the disease that's present there. Okay? Secondary is actually an etiologic definition or classification. So basically now you're looking at diseases that may actually cause nephrotic syndrome. So often this is a bit difficult when you're in medical school to try to memorize this, because this hand over here is, or this arm I should say over here, is more of a pathologic or an anatomic classification, whereas over here this is more of an etiologic classification. So this is the holy kidney cell over here. So here you can look at the entire nephron. Here's the glomerulus, and this is going to be the focus of our discussion with FSGS over here. But the kidney cell is made up of very highly specialized tubules, and then eventually the collecting duct, and eventually you go on to make urine. This is the concentration area where how the kidneys concentrate urine and can dilute urine. Okay? And this is a high power view of the glomerulus. So again, blood will come across over here through the afferent arteriole. It goes through the glomerulus. So these are basically your capillaries. And within that, fluid will come out over here and form the filtrate. And it will go into this area called Bowman space. And Bowman space will then, the urine that's in Bowman space will then go to the proximal convoluted tubule. And again, modifications are made to the urine over here. Specifically, there's reabsorption of your electrolytes and excretion of your toxins. So this is kind of the filtration barrier, and this is really where the disease occurs in FSGS. So how do we classify these? So there's primary, so there's something called membranous minimal chain disease, focal segmental glomerulosclerosis, mesangial membranous proliferative glomerulonephritis, and then there's other glomerulopathies. And if you kind of break this up, so membranous GN, I guess, is basically on the picture. So the pathologist looks under the microscope and says and sees a particular pattern or characteristic over here. So over here you can see that these capillary loops. This is basically the glomerulus again, and these are capillary loops kind of cut in a cross section. And what you're seeing is that these are kind of empty capillary loops, but these are quite thickened over here. And when they're thickened, it's indicative of immune deposits that are present there. And if you do an electron microscopy of this, you'll see a lot of immune deposits there. And a number of years ago, when electron microscopy wasn't available, pathologists had to make a diagnosis looking at light microscopy, and this is what they'll look at. And they basically classify this as something, define this as something called membranous. So what causes membranous? Because membranous can cause nephrotic syndrome. And again, this is a picture, not a disease. And so we have to look at secondary causes of membranous. And membranous can be caused by a disease called lupus nephritis. It can be caused by medications, D-penicillamine, captopril, anti-inflammatory medications, such as Aleve, Advil, ibuprofen, viruses such as hepatitis B, and even cancers can actually cause this picture to occur. So when you get this, you really have to think about other causes that could be presenting this. And if you ultimately do a whole bunch of tests and rule out the secondary causes of it, then you can go on to say this is idiopathic membranous glomerulonephritis. So focal segmental glomerulonephritis similarly is a picture. So it's a focal scarring of the glomerulus. So you can see there's areas. This is all normal here, okay, and this is quite scarred over here. And so it's focal and it's segmental. So and when you look at this biopsy, this kidney cell, for example, is scarred, but another one next to it may be totally normal. And so that's where the idea of the focal and the segmental portion comes about. So again, this is not a disease per se. So could this be genetic? Is there a family history? So with Dan, we were concerned about that, him being fairly young, but we couldn't really find a source for it. Could this be viruses? So HIV can be associated with that. Drugs, could it be heroin? There's also a drug called pamidronate, which is a commonly used agent for multiple myeloma and for a family of medications called bisphosphonates that's used for osteoporosis that you might have heard of. And also in obesity, and also there's a predisposition in a particular group. African Americans tend to have this picture fairly commonly as well. So this is, again, a picture, and then you have to kind of look for a potential source of it. And if you ruled out all of these, and as we did with Dan, then you can say this was idiopathic focal segmental glomerulosclerosis. So minimal chain disease, so again, basically when you say minimal chain disease, it's dating back a number of years ago when the pathologist looked down at the microscope and said, hey, I don't see much much going on over here. This, there's very little change over here, and so we'll call it minimal change, yet the patient has nephrotic syndrome. There's still not a protein. But subsequently, with the electron microscopy, we realized that there's actually a disease process that's actually taking place. These are podocytes, which are basically the cells on top of the capillary loops. And these podocytes are very important in protein trafficking. And basically what happens to them is that they get totally effaced, basically flattened out totally, and cause this disease. Again, secondary causes of minimal change disease, medications, cancers, and also the majority of cases are idiopathic. And this is a fairly common lesion in children. So often in children, the nephrologists during biopsy them, they presume that they have minimal change disease and just give them steroids to treat. MPGN and IgA, so again, this is more of a picture of a very congested glomerulus. So over here, unlike the other glomerulus that you saw, the loops over here are busier because there's a lot of cells inside the loops, but also the mesangium, which is a space that holds up the glomerulus in Bowman space, is expanded. So you see a lot of pinkish material over here as well. And so, and again, causes of this could be infections, could be hepatitis C, which is probably the most common cause of this. Could be chronic diseases such as rheumatoid arthritis, Sjogren's, or even rarely lupus can cause that. And I just want to focus a bit more on this particular picture. So again, this is the most important part that we think causes disease and causes nephrotic syndrome. So again, here are your podocytes, okay? And in between them, they are something called the slit diaphragm. And these things are very important in controlling protein that leaks across, okay? And so it seems that there's damage that occurs over here. There's actually nephrin and a whole bunch of other molecules that don't form properly and often cause a genetic variance of this disease. There's also molecules that are affected over here that affect the podocyte skeleton. And eventually what happens on biopsies is that you see this very flattened version of it. So instead of nice holding hands together, there's no holding of hands. It's basically a flattened version, and then you have massive protein leakage that takes place. Doesn't he want to make you all want to be nephrologists? It's not like the respirology guys, you know what I mean? So, so diabetes is the other secondary causes of nephrotic syndrome. So systemic diseases, drugs, infections, and malignancy. So this is the other arm of it. So when somebody comes with nephrotic syndrome, you always have to think, even prior to doing a biopsy, is that could the person have diabetes? So the most common cause of nephrotic syndrome in North America is diabetes. You could have malignancies, so amyloidosis or multiple myeloma can cause this. Again, lupus pops up. Medications, always have to worry about medications, especially anti-inflammatory medications. Infections, again, HIV, hepatitis B and C, and malignancy. And you can see that the overlap. So you can have an etiologic classification that can overlap with the pictures that we saw earlier. So with Dan, so he had a full workup done. There was nothing really to suggest HIV or viral hepatitis. He really hadn't been on any medications. And essentially he had his whole gamut of workup that all came back as being negative. And so essentially he was referred to Dr. Margetts for the biopsy. And with the biopsy obviously showed focal segmental glomerulosclerosis. So what are some complications of nephrotic syndrome? So what can happen with this disease? So getting acute kidney injury or acute renal failure is a concerning thing. So the disease itself can progress on to kidney failure, but also because of massive volume contraction, it can cause another condition called ATN. So we want to avoid certain medications in that situation. There's therapies, and some of the therapies are also toxic to the kidney. So the cyclosporin, an agent that we use, also causes kidney failure. And because of the massive volume depletion, you get sludging of the flows in the veins, and you can get something called renal vein thrombosis as well, which can also cause kidney failure. The blood clots we kind of briefly touched upon. So as you're losing anticoagulant factors in your urine, you're immobile, you have an 8-fold increased risk of getting a blood clot in the leg or in a renal vein. Infections, so because you're losing the immunoglobulins in the urine as well, you're at higher risk of infections, and specifically encapsulated organisms such as pneumococcal infections or Haemophilus. They get high cholesterol that we talked about. They get osteoporosis, and osteoporosis is really because you lose a lot of vitamin D binding protein in the urine as well. And so this predisposes you to this, but also because of medications that we use, steroids also predisposes patients to osteoporosis. And then lastly, they get malnutrition given the heavy protein leakage that occurs in these individuals. As far as treatment, so again, we want to control the volume. So salt restriction, using this angiotensin converting enzyme, so targeting those pathophysiology, using diuretics, so getting rid of the salt as best as we can. We don't always use anticoagulants, and in Dan we actually didn't, but there is some data to suggest that maybe if your albumin is very low, that we should suggest start anticoagulation, especially if patients have a form of nephrotic syndrome caused by membranous. So membranous seems to be a predisposition to blood clots. Infections, so you can consider vaccinations, though the concerning part is that when they have nephrotic syndrome, they actually are losing a lot of proteins, and they may not necessarily respond. As well, they're also on immunosuppression here, having high cholesterol. So remember, Dan was on a statin therapy, a drug called atorvastatin, to control that. He was on a bisphosphonate to help for the osteoporosis. And then the malnutrition, we kind of promote a normal protein diet despite them losing heavy protein. So this is Dan's medications, so ramipril, furosemide, prednisone, and atorvastatin. His biopsy showed focal segmental glomerulosclerosis. So you can see this area of scarring of the kidney and other area that's actually totally normal up higher up here. And he had progressive weight gain. So we tried to start off on some therapy. So we put him on cyclosporin. We tried him off on plasmapheresis, which is basically trying to see if there's a factor that's in the blood that may be causing this disease. And that didn't unfortunately work. He also went on another agent, an immunosuppressant, to try to target this disease as well, but that didn't help us either. And he rapidly progressed to dialysis within 6 months, and this was actually quite concerning, the fact that he progressed so rapidly. So Dan went on to dialysis, and then went on to actually get a transplant. And Dan, do you want to tell us about the transplant that you got?
I had a transplant a year later back in Halifax. My mom gave me a live kidney, and initially it seemed to work very well. They told us everything looked fine with it for about 3 or 4 days, and then it just stopped. They didn't know what was going on and did a whole bunch of testing on it, ultrasounds, biopsies and stuff, and said that it looked like the blood flow to the kidney had stopped for some reason. So the kidney did eventually fail and was taken out a month later so that I could stop the immunosuppressive drugs.
Okay, thanks. So the problem with the kidney transplant is that it doesn't unfortunately solve this condition. This condition has a fairly high rate of recurrence of disease. And one of the biggest concerns that the transplant nephrologist in Halifax had was that was this recurrent disease that occurred so rapidly, or was there a blood clot that actually occurred? And we never really had definitive evidence that it was recurrent disease, but there was some evidence that maybe there was a clot involved in it as well. So we're still going to look towards a second renal transplant for Dan. So a bit about FSGS. So again, it's the most common form of nephrotic syndrome in adults, but accounting for 40%. It's the most common glomerular disease causing kidney failure in our patients. And 4% of the dialysis patients in the United States have FSGS, recognizing that the population has more African Americans than the Canadian population does. And as I mentioned, this is just a group of diseases with generally a common pathology involving the podocytes that I showed you earlier, but it in itself is not a disease. So as far as the data for FSGS goes, so again, remember there's secondary forms of FSGS caused by a number of different things over here. Viruses can cause, as I said, but also a whole host of congenital disease, but also something called an adaptive response, which is basically patients who, let's say, are born with a solitary kidney may get a wear and tear effect, or if they're obese, or if they have persistent long-standing hypertension, can also get FSGS as well. So the picture doesn't always mean that a bad prognosis. There's something called a circulating factor that's been identified, and we don't really know exactly what it is, but there's thinking that there's a permeability factor that actually makes these kidneys very leaky. And the problem with this is that that factor can be retained forever. And so even in a second transplant or a first transplant, this disease can occur very aggressively and lead to kidney failure. And these individuals can then potentially become dialysis dependent for their entire life. So this is kind of one of the potential thoughts and potential candidates for what this permeability factor could be are probably the most prevalent one is something called soluble urokinase receptor. However, this really hasn't been identified clearly. So as far as prognosis for FSGS, so here's a whole host of diseases that we talked about that cause kidney failure. Diabetes classically over 30 years, membranous will do it in about 25 years. But look at FSGS, depending on how rapid the course is, they can actually develop kidney failure in about 7 years as an average. But remember, Dan was actually more like this. He was straight down within 6 months they developed his condition. So does that actually impart anything? So FSGS, from a histologic perspective, can look quite different, okay? And generally speaking, there's something called the perihilar variant, there's a tip variant, but these are really not prognostically that different. What is prognostic different is something called collapsing FSGS, which is prevalent in HIV patients, but also in patients who get permeginate as well. And this has a very bad prognosis with a very rapid course to deterioration in renal function. These other ones who were initially felt to have a prognostic influence really don't have as much prognosis that's associated with them now. So treatment, so if it's primary FSGS, we're going to inhibit this renin-angiotensin system. We're going to try them on glucocorticoids, so steroids, which Dan was on. And if it's resistant, we put them on cyclosporin, which also Dan we tried with no success. If it's adaptive FSGS, which is because of hypertension or single kidney, then you really want to try to control the renin-angiotensin system and put them on an ACE inhibitor such as this. And secondary FSGS is really trying to target the disease per se. So for example, it's because of lupus, trying to target the lupus and using immunosuppression for that disease. This is just some data about cyclosporin. And again, compared to placebo, cyclosporin had quite a significant amount of partial as well as complete remission. This is a nice study done by Dr. Katran in 1999. So this is really kind of the mainstay of therapy now for idiopathic FSGS. And when this fails, we can try rituximab, and there's been case reports of it leading to a complete and partial remission, also being used in transplant patients as well. In fact, we're using this in one other transplant patient that currently has recurrent FSGS that developed this condition within 4 days after transplant. Okay, so renal transplantation, so like I said, the risk of recurrence varies between 20 to 50%, and it really there's so much variability because we don't really know what the etiological and underlying disease is. So with Dan, unfortunately, it probably hovers closer to almost 75 to 80% risk of recurrence. The familial forms and the ones that are slower progressive diseases with FSGS will have a lower risk of recurrence. An aggressive initial course, again, like Dan's and associated with heavy proteinuria, leading to kidney failure, also has a very high risk of recurrence. The recurrence can be immediate, so within, like I said, this young lady developed it literally within 2 or 3 days after transplantation. And the therapeutic options are pretty much similar, except we do have a heavier emphasis on plasmapheresis, steroids, cyclosporin, and over here we're a bit more aggressive in using rituximab up front. So in summary, FSGS is a common cause of nephrotic syndrome. Like I said, it itself, it is not a disease, but more of a syndrome, and it represents a group of diseases. This is kind of the classification once again. The prognosis really varies depending on how aggressive the course is. And really treatment involves these non-specific therapies, as we haven't really been able to target anything that's specific for the podocyte or the slit diaphragm at the present moment.